I reckon we get started. I think they'll turn up if they turn up. Whose noise is that one?
I don't know, not me.
I'll mute it.
That'd be great.
I was like, that sounds like an aeroplane landing.
It is an aeroplane landing.
Oh, there we go. All right, so if you just want to let me know when you want me to start, and I'll start.
Why don't you start?
Okay, no worries.
I'm going to mute as well.
All right, so this is my annotated bibliography. Does explicit learning interventions that incorporate elements such as goal-directed training, tasks and or specific feedback strategies improve occupational participation in activities of daily living for adult stroke survivors. Okay, so how was my topic chosen? Being a novice to neurorehabilitation, but forever having to explain what occupational therapists do, I decided to explore further the evidence behind what we do as OTs. I had read an article in a previous unit that had already sparked my attention regarding neuroscience links and neuroplasticity evidence that supported cognitive motor occupational therapy interventions with children who had cognitive and motor development issues. With this information, I started to brainstorm a potential topic to research. I reread the original article and looked at the references, and I found the SENSE program, RCT, by the same author as the original article, and thought that was probably a good place to start. I also read up neuroscience literature to find out about neuroplasticity and how and why it occurred. It was like joining up a dot-to-dot puzzle that finally produced a picture of scientific evidence linking explicit learning approaches to occupational therapy interventions. Interestingly, explicit learning instruction techniques, such as when teaching reading, for example, phonetic instruction, has been used in teaching children new skills with great success for years because of the radical changes it produces in the child's brain. Okay, so relevance to my practice, what is currently happening in my setting. Well, my workplace employs one occupational therapist, and that's me. We have a 1:6 ratio of OTs to physios. We're a small site, however, the public hospital next door employs approximately 7 OTs. We're a big private not-for-profit organisation all around Australia. And as the only OT, I'm kind of a gatekeeper. I screen rather than implement interventions, other than equipment prescription, and I give OT specific advice and education. But the public hospital is on the same site and they have a stroke rehab unit. This unit is a multidisciplinary inpatient rehab unit that employs occupational therapy interventions such as CIMT and ADL retraining. At another site for my organisation, they've just rolled out the SENSE program for stroke rehab, and they're currently in the assessment phase. Unfortunately, I'm in WA and this site is in Frankston, Victoria. My site is currently too small for a stroke rehab unit. All right, so the scope of the evidence to date. The OT interventions chosen for review were all aimed at improving client-centred chosen goals in ADLs. The sensory retraining interventions I reviewed aimed to improve upper limb function with the intention that participants were able to participate in everyday activities involving upper limb use such as ADLs. Okay, so the scope. So Kerry in 2010, she identified 2 core principles of neuroscience and learning. Participants in therapy need to be motivated and engaged for learning dependent plasticity to occur, and an explicit focus on learning how to learn, and upheld the notion that the use of client-centred and meaningful goal-directed tasks encourages the prospect of therapy tapping into familiar brain networks that are critical to said task. The literature reviewed identified a set of collective principles for stroke rehabilitation, and these come under the umbrella term of explicit learning. Explicit learning is required for change to occur in the brain and for neuroplasticity to happen. The literature reviewed identified evidence that links neuroscience evidence with occupational therapy interventions. The explicit learning approaches, so specific feedback or behavioural strategies such as somatosensory retraining and goal-directed task-orientated therapy with variability and repetitive practice within the context environment in which the task would normally occur. Supported by the evidence in the literature reviewed, occupational therapy interventions for stroke survivors focus on ADLs or PADLs. However, the tasks within these are client-centred, and chosen by the participant. So the participant is motivated and engaged. They are task-orientated and goal-directed activities and undertaken with repetitive practice and within the context environment in which they would normally occur. These are all identified principles that are required for neuroplasticity to occur and are required under the explicit learning approach. The somatosensory retraining is a specific feedback strategy that produced positive results on MRI scans post-intervention and from participants improvement on post-treatment outcome measures. Okay, so the gaps I identified. Sample sizes in some of the studies I reviewed were just not producing enough power to give statistical significance to the evidence, even if they were producing clinically significant results. The interventions in some of the studies don't seem long enough in duration. For example, there are only 2 weeks in total to produce statistically and clinically significant results with all participants. There needs to be further research to ascertain if the explicit learning approaches identified are universal to all types of stroke. There's not enough high-level evidence to support a change in guidelines for treating stroke survivors in this way yet. And further large studies incorporating all the principles of explicit learning approach need to be undertaken to ascertain if stroke survivors will have better outcomes. For example, if therapy has a multi-principle approach with occupational therapy, ADL interventions occurring concurrently with separate sensory retraining, and whether they complement each other or if they need to be carried out at separate intervals, for example, an intensive 6-week sensory retraining prior to a more typical occupational therapy ADL task-orientated intervention. Further research to identify if better outcomes for stroke survivors undertaking this kind of therapy, and if they're treated within 6 weeks of the stroke occurring, or if outcomes do not differ if stroke survivors are treated, say, 6 months post-stroke or later on. I couldn't find any qualitative studies of the somatosensory training to complement the quantitative studies, so there was no patient perspectives on recovery using this type of intervention. There didn't seem to be any evidence or therapist perspective on the clinical utility of the SENSE program or similar training. No specific evidence comparing these types of interventions taking place in the client's own home versus, say, community group, hospital or rehab unit, and determining which produces better outcomes for stroke survivors. And considering the last point, research and discussions need to occur about cost effectiveness, clinical utility in various settings, and updating the stroke treatment guidelines to reflect this up-to-date evidence. Okay, so the research article example is by Kerry, Wade, McDonald and Mattis, and it's about the SENSE study of the effectiveness of neurorehabilitation on sensation, and it was a randomised control trial. For the method, the authors undertook a randomised parallel group control trial and blinding all subjects, clinical assessors and those who undertook the data analysis. The participants, there were 50 in total, and they had impaired texture discrimination and limb position sense and all tactile recognition. The participants were either 6 weeks post-stroke, but with a median of 48 weeks post-stroke. They were then randomised into either the somatosensory retraining group or the repeated exposure to sensory stimuli group, and both groups had 60-minute sessions for a total of 10 sessions. Primary outcome measured was the extent of change in the somatosensory deficit following intervention, and follow-up at 6 weeks post-final treatment and 6 months post-intervention. Okay, so when I was appraising the article, I used the Joanna Briggs Institute Critical Appraisal tool for RCTs. So was there true randomisation used for the assignment? Yes, there was computer randomised to participant groups, proportional sampling to control side of the lesion and gender, and consecutive assignment occurred. Was allocation to groups concealed? Yep. Blinding to subjects, clinical assessors and data analysis. The authors did point out a limitation that double blinding wasn't guaranteed because the treating therapist may have recognised the difference between treatment protocols. Were treatment groups similar at baseline? Yep, all participants' baseline demographics and clinical characteristics were similar, but it wasn't possible to be identical. Were participants blind to treatment assignment? Yep, masking of participants to both experimental and control. Were those delivering treatment blind to the treatment assignment? Yep, the therapist blinded to control and experimental group, but the authors did explain that the therapist may have understood the difference between protocols. Were outcome assessors blind to treatment assignment? Yep. Yes, they were. Okay, so were treatment groups treated identically other than the intervention of interest? There was no other treatment that ran concurrently with either groups. Therefore, the effect of the intervention group can be attributed to the intervention and not to other treatment. Was follow-up complete? And if not, were strategies to address incomplete follow-up utilised? Well, follow-up did occur at 6 weeks and 6 months post-intervention. The authors state that 3 participants were lost to follow-up, and they explain this as being unwell. However, there was no analysis of the impact, if any, of that loss to follow-up. Were participants analysed in the groups to which they were randomised? It wasn't stated if they were analysed in their allocated groups. Were outcomes measured in the same way for treatment groups? Yeah, but it didn't specify the timings of the testings. The same outcome measures were used for all participants, and it did state that they follow the protocol. However, they didn't give an example of what the protocol was. Were outcomes measured in a reliable way? There was a number of raters, but it wasn't stated. It wasn't stated the number of raters. The training of raters, all assessors were trained for the of the outcome measures and the protocol by the main author. The inter-rater reliability of the outcome measures, the authors state that all outcome measures have high reliability. And was appropriate statistical analysis used? Yes, it was. They used F-taught scores, data analysis, paired sample t-test used, one-tailed test due to hypothesis based on positive findings. And they said that large standardised effect sizes, so the powers in excess of 99%. Okay, so my initial reflections, challenges and barriers to applying this in my clinical setting. Well, there's only one occupational therapist, and that's me. We have no stroke rehab units, and there's no OT outpatient clinic. Sorry, that's just come up. I have a gatekeeper-esque role in my setting, so we don't really do interventions per se. And I also find that the doctors refer to OT, but they still don't really know what OTs do, as it were. Challenges to it being in the stroke rehab unit in the public hospital next door. Well, the public system takes forever to get approval on new protocols, paperwork, and there's strict criteria to pass before anything can be implemented. There are funding issues at the moment, so there's training, cost of official programs, cost of outcome measures if they're not already readily available. The stroke guidelines don't explicitly reflect up-to-date evidence-based practice, and this would be needed to justify a change in their service delivery. Training would be required for all OTs on the rehab unit, so that's cost and time issues. Some management resistant to change, they do what they've always done. There's not enough high-level evidence to convince management what should be implemented at this stage. And however, the SENSE program is being rolled out in my organisation over in Frankston, Victoria. But I think, as I said before, the OT I spoke to last week, they said they're just still in the assessment phase, so she wasn't able to comment on the clinical utility or any of the qualitative feedback from patients because they've not yet participated in therapy. All right, so where to next? What are the clinical implications for occupational therapy practice in stroke rehabilitation? Combining multimodal treatments, so explicit learning approaches such as somatosensory retraining and client-centred activity and task-orientated goal-directed activities. Occupational therapists are client-centred practitioners, and we've been conducting goal-directed and meaningful interventions with stroke survivors for decades. Now neuroscience and OT literature has produced the evidence to support occupational therapy's core practice. The literature review provided the evidence to support the notion that to produce neurological change in stroke survivors, core principles of therapy need to be considered. These are explicit learning approaches consisting of specific feedback strategies such as somatosensory retraining, goal-directed, task-orientated and repetitive practice. The variation in client-centred meaningful activities provides the engagement and motivation for learning-dependent neuroplasticity and increases the possibility of engaging familiar brain networks needed for the activity. Occupational therapy is in a unique position to make big impact for stroke survivors, and where once compensatory approaches were the norm, this evidence supports remediation is possible for stroke survivors. All right, so I've said a couple of questions, but I guess you guys probably have got questions for me too.
Great, thank you.
That's okay.
So, Laura, do you have any, so questions are, in your practice, do you use explicit learning approaches? If you work with stroke patients, what current practices are used in your setting? Laura, have you got comments there?
So, I mean, for me, neither of those really come into play. I'm in workplace rehab. So I'm in a similar setting that I don't really have any exposure to a lot of interventions. It's something that is becoming a little bit more a part of my day-to-day as we're seeing a few more sort of motor vehicle accidents and that. But realistically, it's not something I'm exposed to at all.
Yeah.
So
what about...
Well, to be honest, I didn't really know what it was until... excuse me, it's hot in my house. I didn't really know what it was until I started researching because, as I said, I was a novice to neurorehabilitation. I did my primary school grad dip a couple of years ago, so when I did start looking at the explicit learning approaches, that kind of rang a bell in my head, because that's very much what they do with young primary school children, and it's all because of the similar things with the brain, because explicit teaching and explicit learning does make those changes in the brain. But other than that, I didn't really know until I started doing a lot of this research, I guess.
Yeah, I guess the only time it would sort of come into play for us is we do sort of redeployment. So we do, I guess, what you'd call work skills training in new roles with workers. So I guess it's along the same lines. Obviously, it's still with musculoskeletal, so it's not in the same sort of neuro sense, but it's still using the same principles.
Yeah, okay.
I think that's what's really interesting too, because if you've used the overarching term explicit learning approaches, but it kind of encompasses a whole lot of interventions we use as OTs, isn't it? So you've talked about goal-directed therapy.
Yeah.
So I imagine in both your areas of practice, you talked about feedback.
Yeah.
And I think that when you look at some of the detail, I suppose, that would come in, say, for example, the sense approach or other approaches that are to do with this form of learning, they're quite explicit about the type of feedback you give. So whether it's immediate or about the overall goal, or it's about something specific about movement or how they feel something. So it's that kind of interesting thinking about how we give feedback. So would feedback be a feature of both your practices?
Yeah, absolutely. We probably don't do it in a very structured way, though, in that sense.
Yeah.
Yeah, and in my role, I literally, we have pre-planned joint operations. So I go in there and do my initial assessment and then find out whether I can look after them and equipment prescribe. I'm going into the more cognitive side because we have another ward and they're rolling out mini-cog assessments for as a standardised procedure. So nurses would do the mini-cog, and if age over 65, I think all patients coming in regardless on the medical ward, then I would have to do a cognitive assessment if something's flagged up. And that's a real learning curve as well in terms of for the doctors and the nurses, because none of them have specific cognitive assessments they want to use. They just say, can you do an MMSE, which is kind of mini screens for cognitive issues, but doesn't screen for dementia or anything like that. So for me to have to educate them, I guess, as well. So the whole feedback in terms of interventions doesn't necessarily apply for me. I kind of screen and then refer on, and that is purely because I'm the only OT. I mean, my organisation didn't have an OT for 2 years until they employed me. So I'm slowly trying to build up the kind of OT thing, and we're hoping to get another OT within the next 6 months. But yeah, I literally am a screen gatekeeper kind of OT, so no, unfortunately we don't.
And yeah, look, that's absolutely fair enough. And I suppose it's that thing too, isn't it, that they're kind of principles of intervention. Because if you think about OT practice, that you're talking about being client-centred and meaningful, and therefore that's more motivating, and therefore and whether that's a particular job or work skills or also what you're saying about equipment prescription, potentially, if you're teaching someone to use something, there's repetition, it's goal directed, it's engaging them, it's giving them feedback on whether they're doing it. So it's kind of, I don't know, it's basic learning principles that we sort of apply, isn't it? Even if
But I guess what's exciting is now we've actually got, I think what excited me the most is we've always done this as OTs, and we kind of know it works, but now we've actually got kind of scientific evidence that backs what we do. And I remember chatting to some of the physios about it, and they didn't quite get my excitement. I think because as physios, they've always had that kind of evidence there in terms of you can measure with exercises, you can measure muscles and you can measure this. But with OTs, a lot of ours was I guess, the feedback from clients saying, yes, I can do this. And with like with the COPM, I know the COPM is used a lot, but that while you can quantify those results if you have a lot of people doing it, at the same time it's still client-centered goals, and then feedback from the client saying how well they think their life is improved.
It measures a particular thing.
Yeah. So, but yeah, this excited me in terms of going, well, I always knew why I did it, but now I can actually prove to people this is why it works.
Yeah, no, I agree. I think it's amazing to see
Yeah.
changes on the brain linked to functional performance outcomes. Definitely.
Yeah.
I've got one question. I'm interested. I looked back at your question,
Yeah.
research question.
Yeah.
So if you're looking at this, so this particular article,
Yeah.
how do you think it relates to, I think your question was, and I've got it here because I was going to put it up, so I've got it in front of me. Do these explicit learning interventions incorporated X, Y, and Z improve occupational participation?
Yeah.
ADL. So how do you reckon this particular
the sensory retraining from what I read in the articles, because basically what I did, because it was 6 articles, I chose 3 from, say, a typical OT intervention with ADL, this kind of thing, and 3 with the sensory retraining. And from what the articles, basically their aim, obviously it's not specifically ADLs, because a lot of it is just sensory retraining with like tactile stuff and all that kind of stuff. So, however, their kind of, what's the word, justification was that this training will assist in the participants then going on to be able, because you need to be able to grasp things, you need to be able to use both hands, you need to be able to know where your limb is the proprioception, you need to know where you are in space to be able to carry out these important activities such as dressing and cooking and all the stuff that we take for granted, I guess, in every day. And that's how they justified that this retraining it needs to be done so these people can then participate in activities of daily learning. So initially I was thinking, well, is it client-centred? Because are they actually choosing to do the specific things that the therapists are making them do? But it kind of goes on with, because it's so specific in the sensories, because they're looking at kind of pressure and pain and temperature and positions and that come from like the muscles and everything, that needs to be done as a kind of foundation, so then they can go on to participate in, you know, maybe ADL training, or at least they can then start to use those limbs at their affected side within everyday use. So they're encouraged to then go and use it. And does that make sense? Sorry, I'm trying to make sense of it.
No. What you're saying is making sense. And I suppose what I'm hinting at is that idea of the language around the word participation, because what you're saying makes sense. But that idea of in terms of measurement, or outcomes, just thinking about, you know,
how could it be measured
specific to the actual definition of what if you think about the ICF and you think about activity versus body structures, say the pressure and tactile, activity might be the cooking, and then the participation is another measure. So I suppose it's making sure that, I'm not actually sure it measures participation. I'm not sure it does.
No. Well,
activity limitation, maybe, activity?
Yeah.
Anyway, it's something to look into when you're reading it.
Yeah, because when I emailed you, I did think, because I was thinking, well, actually, it's quite broad, and it wasn't. And is it more jargony than actually something that can actually be measured? No.
It's just more about the definition of participation.
Okay.
It could still be about occupational activity, but participation is a different measurement tool. It's a different type of measurement. So you could very well look at it, and they may not measure it, but you've just got to make sure that language is specific. But you may, like, I can have a look at what you've come up with in your annotated bibliography as well, and chat about it as well. So that's fine.
All right, no worries. Cool.
Okay, great. Have you got any other questions, Laura?
No, it's just interesting for me. I'm just listening. I guess because it is so different than what I do. I don't do a very traditional OT role, realistically, is what it comes down to. So,
but it's and I think it's kind of just interesting. And of course, you know, coming into this subject, you don't have to have that background.
Yeah.
You know, and it's about learning. And I suppose too, it's about trying to get to that depth of understanding about what does it mean that's similar to what you do, because there's lots of similarities really, and sort of applying it that way. So it's about stepping outside your comfort zone in some ways and marrying your current practice and knowledge with some new stuff as well.
Yeah,
it was very novel to me because, as I said, I've not done neuro rehab, and I think we had a subject in my undergrad, but that was quite a few years ago now. So for me, it was very. But the thing is, because I found it so interesting initially when I started reading all the stuff, that kind of engaged and motivated me to kind of learn more and stuff, because actually it's what we do, I think, in general, not just on what I've specifically chosen to do about stroke. It is, I think, across the board what OTs do in general. So from that perspective, I think from even if you are working in work cover, or because I've done that before, I think it still can be quite applicable.
It's definitely still applicable. It's just an interesting one to reflect on. How does it, in a broader sense, as you say, not necessarily related to neuro conditions, but just across the actual, just people.
Definitely. It was how people learn, I guess, and how the brain, and I guess what the best options for learning and the environment to learn within, and that kind of thing.
And maybe it's even interesting to, more knowledge in that area is when you are thinking about referring somebody onto something, you think about screened for sensory loss, and there's an intervention that's evidence-based. So, your referral and understanding, yes, they've got the cognitive capacity or not. Yes, maybe they really need to go to, intensive rehab or have a home program where they can access that.
Yeah.
So it's different kind of knowledge for different purposes as well, isn't it?
Yeah, absolutely.
Great. Oh, very interesting. And look, I'm really glad that's an area you're really interested in. And that was the idea behind the assessment, really, is to find something, well, I'd like to know more about this, whatever it is, and then, extend your knowledge. So that's great.
And I think learning how to research as well, because I probably find it really difficult, like just getting that question down, like we're going back to the question. Actually, I've learned a lot in terms of what you want to find out specifically and how you phrase it, and that is so important in terms of then going off to find the research. But it doesn't come easy to me at all. I think I think it's
a real skill, and I think it's something we all I've worked at the university now for 6 years, and I've done a master's degree, but I still feel like it's a skill that I'm continuing to develop.
Good.
No, definitely. And look, that's all that stuff that we included, reading about the enablers and barriers for therapists and being evidence-based. They talk about their lack of confidence in searching, and searching comes once you've got a question. So, it's all kind of interlinked.
Yeah.
It's definitely something to practice.
Yeah.
And that you are practicing, which is great.
Yeah.
All right, fantastic. Laura, do you want to go ahead? So you've got your slides to share?
Yep.
Great.
I'll just make sure it gets the right one. Why has that done to me? Has that come up for you guys?
No.
It's come up as, it's weird that it just went into my Zoom screen.
So you found the little green, that's it?
Yeah, I'm getting there.
Yep, right.
All right, that should be whole screen now. So obviously, as we said, I'm in workplace rehab. So realistically, I wanted to look at how does this apply to me. I've found it, as I said, really interesting on a general level. But I wanted to sort of think, so my current scope of practice, I actually don't have a very high caseload at the moment because I manage a team here. However, my team I've got a multidisciplinary team. So I have a physio, a psychologist, and an EP. So no other OTs, but obviously we're doing more and more CTP in addition to our normal sort of workers' comp caseload. And with that, we're getting a little bit more, we've been noticing in our office here, of sort of some of these conditions and it's something that for me it flagged that I don't know how to deal with them, realistically, is what it comes down to. I get one of these referrals and I do my normal initial assessment. I can look at my return to work, that sort of things. But when it's coming down to where do I actually go, how am I going to sort of have best practice with it when it comes to, I've got a guy at the moment who he has had a brain injury, and we're going, I know that there's cognitive impairments, I've done a standardized assessment, I know where his issues are, but I'm going, I don't actually know in terms of then how do I apply that back to his return to work? What am I needing to do? So the other thing is, obviously within our industry at the moment, there is more of a focus on trying to have evidence-based practice, and there's a push from our referrers to be using standardized assessments and to be able to show actual objective outcomes rather than us just saying, well, yeah, we did what we could.
And they're better or they're not, yeah.
Yeah, exactly. These cases for us are often ones that, in terms of their return to work, are negative outcomes, basically, is what it comes down to. We do some ADL retraining, we do home assessments, so equipment prescription, the same sort of things. We do a lot of home mods in these circumstances, but the return to work side of thing is the thing that we seem to fall down, and it seems to be these are the ones that slip between the gaps, realistically. Our musculoskeletal seem to go fine, but these ones are a bit intimidating. So it was, for me, this was just, I wanted to look at it more of quite a scoping review. So in terms of that, I just literally went with what are the current best evidence rehabilitation guidelines for return to work for patients with brain injuries. I didn't limit it any more than that because I just wanted to get an idea of what's even out there that's return to work based. So, and then the sort of second part of that I want to look at are what are the implications for occupational therapy practice within the workplace rehab sector. So going, okay, what's actually out there? Is it associated with what we do, and how can we, like, what's it got to do with us? So this was basically my search terms. I started looking in and I found quite a lot of old stuff that was returned to work, but nothing particularly new. So I actually limited it because I wanted the current evidence. I didn't want sort of, your 1991, which is what I was coming up with when I started originally searching. Obviously, I wanted participants that were working age, and that return to work had to be the primary outcome. So I found a lot of articles that talked about productivity as sort of, not even a secondary, but just as a sort of side note, or they'd say that that was going to be the next stage of whatever the client's intervention had been, that, they were now independent in ADLs with this, that and another because of this intervention, and then they'd focus on return to work. But I could never find the follow-up that had actually looked at the return to work side of things. So I had a lot of difficulty finding things it was difficult to find anything, and it spent a lot of time, and a lot of what I came up with isn't necessarily from occupational science or occupational therapy literature. A lot of it came from vocational rehab, just basic medical journals looking at return to work. However, when looking actually at it, a lot of it related back to occupational principles and looking at, okay, well, I can see, again, what I was sort of saying with my question about what are the implications of this? I can see that there's information here and that it seems valuable, but how do I apply it to what I do? So these were sort of basically the 6 articles that I have come up with and chosen. So there's 3 on this page and 3 on the next page. So only two of them that, as I said, I found used actually OT models or interventions. One of them was a client-centered OT program that looked at retraining for everyday technology in the workplace to try and obviously increase their ability to utilise that technology and therefore increase their ability to complete their work tasks. And the other one was using the Moose, so the model of occupational self-efficacy, which was an interesting one. It was just a small case study, but it was, and in terms of when I looked, I had a couple of other articles that when I analysed them and when I did the analysis of them, they probably were higher up methodology-wise. But the case study, because it was exactly using an OT model, I sort of wanted to include it because it talked in our language and it went into detail that I think a lot of the others didn't. So 2 of the others that I used were qualitative case studies, basically looking at the client's perception of the things that influence their return to work, which I found really interesting. And they were the ones that for me sort of sparked going, okay, these are the things that possibly we're not looking at enough. We are very driven by our referrers and, you know, that side of things, and going, we feel like we're doing what we should be. You know, we're doing some upper limb retraining, we're going in, we're teaching you how to use a new piece of technology, we're taking you into the workplace, but we're not looking at the actual person side of some of those volition and more of the beliefs, and using that side of OT as much as we could be. And then one of them was a systematic review of interventions. I only found literally one review. And one of them was looking at a study of intensive residential program. However, it was a comparison 12 months post participation in this program of whether or not the person was employed. The only thing that it was interesting, but I guess the thing that made me question it was that it was a multidisciplinary program. So it was hard to pull out from that, you know, what was the OT. However, I thought it was still a valuable inclusion, because at the end of the day, it was looking at, well, what did work? It still described in depth what the actual program included. And I thought, okay, even if some of those aren't aspects of OT, doesn't mean that there's not valuable takeaways from why did it actually work. The one I chose to have a look at in depth more, and well, show you guys today, was the so it was an effective return to work interventions after acquired brain injury, a systematic review. It did come out, it actually was quite a thorough review. It comes up against the NHMRC levels of evidence as level 1, because it is a review of randomised control trials. So it focuses on looking at the effectiveness of interventions specifically for return to work. So it was the only article I found that really focused on return to work. It looked at, you know, what were the outcomes, it looked at factors in terms of, as I'll go on, it didn't, a lot of the ones I found looked at reviews of factors that influenced return to work. So looking at, okay, how many days in hospital, and gender and age, and all of, you know, their amnesia scores and that sort of thing. But none of them really looked at, well, what was the intervention and what difference did that make? So this was an interesting one in that sense. So this one's method, it did review in the end 12 studies, 5 randomised control trials and 7 other designs. All of the other designs did have a control, which was great. The method that they used was quite rigorous. They extracted all the data from those studies. One author did it, and then a random sample was then further analysed by an additional 2 authors to make sure that they had they corresponded. And then they used a list by Van Tulda to quantify the methodologies of their chosen studies, and they rated them as either high, sufficient or low based on their methodology and their findings. From there, they then did an evidence synthesis across 5 levels of evidence. So based on how many articles they had, and they list all this out in the article. So their methodology is quite strong in that sense, that it's quite transparent, that they went through and said, okay, is it strong, moderate, limited, indicative, or there's no evidence for that type of intervention? As I said, like, the criteria was clearly explained. I assessed it against the McMaster qualitative review form. Even though they included randomised control trials, they weren't themselves able to perform a meta-analysis because the populations were so different. So they've used a qualitative, basically, assessment of that, and I just went with the same form. The findings from that was what I found the most interesting. So they basically came back as saying that the strongest evidence was for work-directed / based intervention with education coaching. So they basically said that all the interventions they looked at often comprised multiple components. So it wasn't as if they came back as there was one certain program or one certain intervention that looked at one thing. All of these seemed to have multiple elements, and when I looked at them, they also had quite ambiguous wording. So I found that I read that and went, work-directed based intervention with education coaching, I don't know what that means. Mm-hmm. And that was one of the gaps that I found. They've said that, but they haven't actually given a very good description of what the intervention was. I'm sure if I went back and looked at all of those articles, I'd have more of an idea. And I looked into a couple of them. But I think that was the thing. By picking up, if you were to pick up just that article, I wouldn't really know where to start still. So as I said, it doesn't consider the interventions from an occupational therapy or science background. It doesn't identify who carried out the intervention as well. Doesn't clearly describe the work-directed intervention components or how this was carried out, determined, evaluated. It didn't identify any of the outcome or assessment tools used by different studies reviewed. Obviously it didn't look into the experience of occupational identity or worker role satisfaction from the client. And then I worked out after I'd gotten this, and it was 2016, that it was still actually reviewing old articles anyway. So having said that, I am looking to include it because it is the only thing that I've even found that even lists like an actual intervention. So based on the 6 articles that I've got and a couple of others I've read, it does seem that clients with mild to severe brain injuries can have positive vocational outcomes. The evidence seems to be from vocational rehab, not occupational therapy specific. The thing that I took away from a lot of it was that both the personal and the environmental factors were equally important, which I think within workplace rehab we not forget, but we don't communicate that very well to our referrers. They're quite okay about us saying that we want to modify an environment and that there's this, that, or another barrier within the environment. But if we talk to them about this belief or, the loss of occupational identity, they don't understand that as well. And I think what this evidence suggested was that using a model within our practice for workplace rehab that easily explains that. So I was thinking, the PEO or something that's quite simple and straightforward for somebody who's not an OT to understand might help us to implement some of this evidence back into our practice. The other thing that was the evidence suggests that the involvement of the employer and use of the workplace environment were highly important. So again, work skills training to occur in context rather than in our office, taking them out into their workplace and doing, and I guess that's talking about back to what Stephanie was talking about that explicit learning. It's one thing to teach it in the office, but generalizing it to the actual context and into the environment is separate again and is different. And I think we need to, I know our office here in COFS, we need to probably focus on that a little bit more. The thing that I took away from this article in particular, that it seems to rely a lot on coaching and education from the clinician. Therefore, the outcome may be reliant on the skills and experience of the clinician rather than the actual intervention. It seems for a lot of return to work, it is a lot about motivation and, negotiation with the employer rather than actual doing a set intervention of, an 8-week intervention that you do this, this, and this on each session. It seems more about that therapeutic relationship and about the clinician skills. So I guess that's a difficult one again for me because I'm sort of going, I'd like to try some of this, but I haven't had somebody to model it off or see somebody else who's got really good skills in dealing with this sort of population. So I guess for me, barriers and the implications of this were the time required to address the personal factors and facilitate acceptance of change in occupational identity. A lot of the articles were looking at a 6 to 12 month process. We don't have that. We basically, if we can't show an outcome, it just gets taken off us is what it comes down to. They want immediate outcomes. They want cost-effective outcomes. So I think one of the things that I wanted to look into more was looking at, okay, well, from what I've found about what's important and what factors are going to influence this, what can I marry up? What assessment tools are going to show a change in these factors that I'm looking at, and going, sure, they might be self-reported, but there is more of a push from our insurers now to understand that it's important if the worker is self-reporting that they're getting progress out of it. They're starting to understand that a little bit more than, as we were saying, the physical, range of motion's increased by 10 degrees. They're used to that sort of language. They're not used to more holistic and client-centered. I just wanted to look into that a little bit more for my own sort of practice. The The same thing is the time required to implement work skills training and supported placement. I'm in a regional area, so trying to get a supported placement and an employer who is willing to take on a worker who's going to need goal-directed training and explicit, work skills training on each and every task, it's near on impossible. They won't do it. So I think, possibly for us, that means looking at things like, well, where else could we do it? Can we get something that's contextually a bit closer to at least their workplace? That it's not just with getting them in to do, we might not do fine motor stuff that's exactly that, but we get them in with their actual tools rather than just working on hand strength and that, using actual tasks that relate back to what they do as a worker role. The other thing is that the financial difficulty in implementing long-term intervention, as I said, we are pushed to have as low costs as possible. If that means that I'm having to go out and see a worker, for an hour each week, it's just difficult to justify that when we don't. It's not as if the workers come to us under their own. They're not either, they're not community health. They're paid for by the insurer, is what it comes down to. So I guess it's about being able to quantify that to them and being able to show that, well, what we're doing is worthwhile and it is valuable and that there is evidence base to back it up. I guess it's the same thing. We know what we do and we know that it's valuable, but it's just about trying to get somebody else to understand that. And then the thing that I found most interesting is that there was such limited evidence on standardised assessments that were anything to do with return to work, that were return to work based. It seems like a lot of the assessments, sure, they include productivity as an element, but it's never a main focus from what I found and from what the evidence is showing to date. And I guess for a lot of working within this industry, I think has for me highlighted that for adults, of working age, the worker role is so important. And when they lose their sense of identity that's tied in with that, I think particularly for populations like this that, like the guy that I'm working with at the moment, which is the first client I've worked with a brain injury, he was a bricklayer. So, and he's not going to be able to go back to bricklaying from his musculoskeletal side of things. However, he's also had a brain injury, and because of that, we're having a lot of difficulty trying to work out, well, what can he do? And he's got this real sense of loss, because not only can he not physically do his role, he cognitively is struggling to even think about, well, what else could I do? How else could I adapt what I already know how to do? So it's been a really interesting one about going, well, how do we assess that? How do we address that at all? So yeah, and there was just really limited options for that. And I think because it's not something I've looked into before, I haven't looked for a standardized assessment tool or anything for that sort of population. It was that. And when I did the research, I couldn't find anything. So where to next? This is more, I did my where to next because I feel like I need to do some more research and looking into, well, what else can I find from this, sorry, I'm in my work mobile. From this sort of background evidence that I've found, I wanted to see, well, what sort of OT models would work within the workplace setting. Obviously, I've sort of said, things that are targeting more of those personal factors because they seem to be a recurring theme that was popping up. Looking at the coaching and education, what specific strategies are they using? I want to go back and have a look at those articles that talk about coaching and that. And even though they're older, I want to sort of see what language they're using to be able to go and then see, well, what's the current ways of implementing that. And looking at assessment tools that have been used with this population in a work setting. I still want to try and see if I can find if there is anything, even if it is older evidence possibly. And then the other thing I wanted to have a look at was, are there any sort of time-constrained specific vocational rehab programs that have been used potentially even with other populations that we could sort of put back into this target? So going, okay, well, this is addressed, as I said, like the remotivation process. We've used that previously with with some of our mental health, some of our clients, and going, okay, well, the evidence from those studies, is that similar to what some of this exploratory scoping evidence is saying needs to be addressed to say, okay, well, maybe this is potentially something that could go together, I guess. So that's basically it. I didn't put any discussion questions, sorry.
It's okay.
I wasn't really sure what I wanted discussed.
What I think is interesting is you've raised what the annotated bibliography is supposed to be about, which is it's a start looking at the scope of the evidence around what you're interested in, and then refining it depending on what you find and what you want to find out more about.
Yeah.
And write to and think to. So I think it's not surprising that's where you're at, really, because that's what it's about, saying, there's a little bit of qual about this and that's interesting, and there's not any effectiveness intervention studies about that, so that's really interesting. So
I think that was the thing. To be really honest, I expected there to be more. I just expected it was one of those ones, because I've done this is my last subject, so, I've looked into quite a few other things within workplace rehab, and it's popped up. And this was the one that, for some reason, return to work it hasn't been focused on.
I guess there's a lot of issues with cost. Like, I worked, not in the same as your role, I kind of, we worked with a VOC rehab company.
Yeah, okay.
But there was a lot more case management rather than actually doing interventions again.
Yeah.
And a lot of it was all based on cost. So the insurer and the employer, they wanted what was going to cost the less. And it was basically, we want them to get back to work as soon as possible. And if they're not going to do this role, again, we need to know what they can do. So then you'd assess their function in that terms. There was no, it was basically what can they do now? And then look at trying getting treatment for, say, physio treatment. A lot of it was physio treatment, like exercises and strength programs. There was nothing really OT specific that I can remember. But I guess just listening to your presentation, because you were talking about acquired brain injury, in terms of remediation versus compensatory, like, I guess you as an OT would want to be able to remediate that, get the best they could be, but find that there's just so many barriers to you even employing that kind of notion, as it were. It's more of, right, what are we going to do now, rather than what could we do if we had 6 months worth of intensive, I guess, OT intervention.
And I guess that, for me, that's the issue with my industry. But I think the thing that I found interesting is that even from an outpatient rehab unit point of view, there's very little. It's such a huge role, and it plays such a big part in, most working adults' life, and yet it hasn't been focused on. And I guess, sure, if a person, and I guess we always prescribe in our office to the sort of notion of, okay, well, they need to, really, before we can look at work, them returning to work, they need to be able to get up and get themselves showered and get themselves dressed to go to work. But once they're at that point, it's as if they go, okay, well, we've done those most basic things. We're not going to follow through to that next level of, okay, let's get them back to all of the occupations they want to do.
And I guess they're kind of going through a bit of a grieving process, because they've lost their occupational identity, and it's just been taken away from them. And then that's quite a process in itself, I think, that they have to work through to then be motivated, I guess, to then go and try something different, or to do something of lesser, I guess, I don't know, for example, like I just recently had a guy who fell off some scaffolding, and he's broken his wrist and he's broken his ankle, and he's having to have plates put in both. And he's 60, and they've pretty much said, look, you're not going to be able to go back to doing that again in the next 18 months. And then he's going, well, I'm going to be retiring in probably 3 or 4 years. What am I, so he's going through that whole, this is what I've always done, and now all of a sudden I'm not going to be able to do it anymore. So he's trying to, I guess, psychologically process that, as well as then eventually obviously going on to more therapy to get him back to a position where he can go back to work. But he knows it'll probably be in an administration capacity.
I think that's the thing. There doesn't seem to be anything that helps that process. And that the only one that I found, as I said, was the model of occupational self-efficacy. And it ran through quite a structured, phased program, 4-phase program of, the first 2 stages were about acceptance and understanding of that sort of occupational change and processing some of those emotions. And then it looked into, okay, taking them back to the workplace and doing the actual more the compensatory and basically readapting and coming up with new ways of doing their things or going to a new workplace. So it was literally the only one that had that process and that did address those personal factors in conjunction with the environmental factors and understanding these are the barriers to, and it was interesting because it talked about these are the barriers to implementing a program like that, and it talked about, as I was saying, things like for them financial constraints. So it's all good and well for them to say, well, you need to go and do work-based work skills training, but if they're only going in there for half an hour, it's talking about for the client, they've got to get themselves there. They've got to pay to get themselves there. They've got to then do all this basically, and that then often that the roles they end up being able to take up are their low-paid roles, and basically they've lost their normal lifestyle factors, their ability to feel like they're able to provide for just for their own basic needs. So you've got that lost side of things, and that it was talking about, you know, people going, well, you know, I now don't have any prospects, and about how do we as OTs focus them back onto that change process, I guess.
Yeah. Well, I worked up at a kind of not a rehab unit per se. It was outpatient, but it was an intensive 2 weeks that the insurer would send them to and pay for them to go to and pay for them to stay. This was up in Queensland. And as an OT, all I did was pretty much was education. So I'd do presentations and educate them. There was no intervention over those 2 weeks because it was more, they would do the exercise and they would do the physio and they would do the psych. But it was, my role was just education and advice. There wasn't actually interventions per se. And that was just the role that I took on. And I think that seems to be the thing with vocational rehab, that OTs don't tend to have a lot of scope. Well, they don't really employ OTs to do interventions that, especially, I don't know, I guess with acquired brain injury, we could do so much with it, but maybe it's more about educating the insurers and letting them know actually what OTs can do, and how much, how much benefit we can actually give to these clients and stuff. Yeah,
and it's an interesting one because I find even when I had my current referral that I have sitting there that I'm working on at the moment, when it first came through to us, it was interesting that their first thing was, we wanted to go to a psychologist.
Yeah.
He doesn't have, sure, as much as, yes, he's got those grieving processes and those sides of things and adjustment to his injury and that, his main issues were around the fact that he couldn't do the things he wanted to do. And by finding him ways to do the things he wanted to do, that was actually managing his psychological symptoms without him having to sit there and talk to a psychologist. And it was me having to explain that to the insurer. That took quite a while for them to go, oh, yeah, okay, I can see that that's a more active strategy. And I think it was just interesting that there's not that focus. Sure, I get it from our sector. I can see that because of the financial constraints and that, but I was interested that there's not more just in general.
Yeah. I think it's also interesting that you've kind of, maybe this is too far outside the scope, but you touch on many factors to explain why people aren't going back to work. So you were sort of saying about the personal barriers and the people, whether it's whatever those are, and understanding brain injury. We know that people have reduced insight into what's changed, and their capacity to set goals is challenged because of that insight. They, even though of course we want to remediate the underlying changes, there isn't good evidence to suggest that that's actually going to happen. So it is around adaptation and compensation and thinking about the environment and the task and roles and things like that. So it is interesting, all those elements that you've got to think of in terms of rehabilitation with someone with cognitive changes that you're then trying to translate to a return to work context, aren't you?
Yeah.
In terms of, well, when is somebody able to be ready to do something different? Or yes, they're not going to transfer skills from one environment to another.
No.
To do goal-directed therapy in in the setting doing the task, potentially, depending on what their capacities are. So it's kind of interesting. It might be interesting to be thinking about the evidence around cognitive rehabilitation or...
Yeah, and I went down that road thinking I'm sure I'm going to find something that's that way, that's got return to work, and I still struggled. I went down...
But maybe it won't have return to work. Maybe
it's just more the cognitive side of things. And I sort of, that was where I started looking into going, okay, well, one of the issues I'm having with this gentleman in particular is that he has memory deficits as a result of his brain injury. And I went, okay, I've given him, you know, as we're saying, I've given him education on some strategies that we could utilise, but it was more I wanted to look at, okay, what's the evidence around that? But then I went, I just want to look at how do we get these people back to work? Because at the end of the day, as much as I would be looking at that one specific thing, my reason for looking at that is a bigger picture of return to work. So,
sorry, I didn't mean to interrupt. You go.
No, that was it. It's fine. And I think the other thing was, it is interesting that all of those factors, and as you're saying, that they, as we know, like brain injuries don't have great insight, and a lot of the research I found was talking about those person factors. But again, it doesn't take it anywhere.
Do you reckon that the actual return to work, obviously that's the end goal, but maybe you need to look at if that's the end overarching goal, there's going to be little goals in between, and one of those not small, but one of those goals in between is obviously cognitive rehabilitation, and there probably is a lot of research in that. It's just, if you take the return to work part out of it, you might find the information that you need, and it might snowball.
It is more of that scoping. It goes back to, what I'm looking at is quite a scoping review in terms of, and that's why some of the articles they don't have anything to do with OT, but they were around perceptions and workers and employers' perceptions, and looking at more of that. Okay, well, what can I use to support what we do in that, and what is going to be important for what we do in that sector. So yeah, I mean, I need to just keep looking. The other one that I found really interesting that I thought there might have been more around was that I found only one article around using like virtual training, which I thought might have been for work skills training. I thought it might have been something that had been looked into more. And the one article I found was from I think it was from 98 or something. So it was old, and I couldn't find anything since.
No, and I think the conversation we had in terms of the cognition topic, and it's that concept of thinking about, well, what's the approach you're taking in terms of intervention? Where's this person at in terms of their capacity? Can they learn? Do they notice when they have problems? I can't remember what the other question was, but depending on what their particular barriers are would be how you went about the intervention. So if there's someone who doesn't have the capacity to learn and doesn't notice their problems, then they're likely to require very task-specific, let's do the same thing over and over. Whereas someone else who has a higher level, I still have problems, like my memory's not very good, and I notice it. So you then use a higher level approach. So I don't think it's going to be very difficult to find the answer, because it's so individualised depending on the person's barriers. So I think your concept of thinking about, well, what is there about to return to work, and what are the potential barriers that come with brain injury that link to that, I think it's probably a smart way to go where you've ended up, because it could be around lots of those factors are contributing to that, and that's why your intervention has to be so individualised. You can't just have a one size fits all. So it's kind of the features of what you have to do to think about return to work for folk. So yeah.
Do you think it's worth focusing back onto one of those small, as we're saying, sort of one of those more specific areas, or whether it is still valuable to be going, okay, looking at it from a more scoping, what is going to impact, and what's those influencing factors?
Are you okay? Because I feel you both have sort of an opportunity to put forward your current thinking. I just wonder if it's worthwhile, once I have a look at your annotated bibliography, to see where your whole thinking is. might be easy to give some feedback then.
Yeah, yep.
So, because it's to say yes or no to either way, it's kind of the big picture of your story in some ways. So, because I think if you go really specifically to cognitive rehabilitation, for example, you're still going to find there's not very good evidence, and it's broadly around the generic idea of cognitive rehab, but that could be
rather than just a
memory deficit versus someone who's got an attentional deficit versus someone who has something else. Your intervention still might be different. So I don't know if that's going to get to the answer either.
Yeah, and I think the thing that I found the ones that I think may, as I said when I was reading through them, that made the biggest difference for me were the ones that were talking around that perception, that lived experience of the worker, and about, okay, well, at the end of the day, that's what matters to them. You know, that's what's going to make that difference about what intervention I do choose. And it's not necessarily about the intervention that's going to make a difference to the return to work outcome. It's about addressing those person factors and addressing what their subjective experience of it is.
Yeah.
So, and I think that's sort of what I took away from it so far, that, you know, even looking at, you know, that one that did the review of all of the most effective, it came down to coaching and education, and that came down to, you know, a clinician's personal skills, because they're going to be able to address a person and understand what that person might be going through more so than somebody who's necessarily inexperienced or somebody who's not aware of, or like myself, aware of what those person factors were and what that person might be going through. I think that was sort of where I was sort of heading more with it, is looking at some of those, because I've found a few other ones around that sort of side of things.
Well, and in some ways it's a bit like, you know, you think about chronic pain, you know, it's a generic concept, but there's a lot of individual differences depending on that person, how you might then target what you're doing. And similarly, you know, you may have, for the group of people who have some insight but still unhappy, but you can help them learn how to check whether they've got any, you know, if they make mistakes. So they've got to process how to check the mistakes because of whatever reason why behind the mistakes. So it's kind of, it is difficult to come up with one answer. And I think understanding sort of conceptualising this group of people broadly, and then thinking, well, yes, how that translates to a context of funding and lack of insight and all those other, how do you then find out what's most important for that person or what you need to address for that person? That's the kind of takeaway, like you're saying, rather than thinking there's going to be an answer to what you do. And then, you know, and it is interesting to think, well, actually only a certain percentage of people actually into a return to work into that insurance sector. And depending on their funding, you know, work cover versus, so for Victoria, the Transport Accident Commission, people go back to work, but the funding model is quite different, and it's much more of a, I would suggest, have a rehabilitation element to it.
Yeah, well, that's like my CTP ones, the same thing. So, my CTP ones are very different than workers' comp ones.
That's right. But and I suppose it's about having more knowledge to guide your conversation about saying, well, this person at the moment doesn't have the insight into being able to be ready to change jobs, or, you know,
they haven't accepted that.
That's right. So therefore, maybe this has to happen before that. I don't know. Because you said, like, you're right, it's highly complicated. I think probably I wouldn't change your tact at the moment. I think you're probably going around the right. And I think it is good to get a broad sense of what's the qualitative stuff and what's quant, you know, what is any effectiveness of interventions. And look, sometimes the answer is there isn't an answer. But searching to find more information that will help you guide you in your practice is where your question wants to direct you.
So which I mean, there's definitely, even at these early stages, this definitely has.
Yeah, great. And I think that's, as I said, this is about a process of getting something of value, not just putting an essay in kind of thing. So that's where your question, your search needs to be systematic to your question, but it's going to evolve in terms of how you might alter that through the process to meet your needs. That's useful in the end. So It's very interesting. It's what I love about this subject is how varied the conversations are, because they are hopefully specific to your own work context. So it's useful.
Can I just ask, can you hear me?
Yep.
Oh, good. I've just had, my kids have come home with my husband, and the youngest is having a meltdown. So I had to put my headphones in. I've not used them before. So I just wanted to make sure.
I sent mine out.
Well, they've been to the park, and then they've come back, and the little one's only 2.5, and he's managed to get himself completely soaked. So my husband just sent me a text saying I've got to get him inside in the shower. But yeah, so I just had a quick question in regards to the wording of my my question. I know I've sent it to you, and I just wondered whether you were able to have a look at it, and just whether, because obviously going back to the participation thing, with my other subject, I had Anu Bhakti kind of give me some guidance on that question, and it was really helpful. And that's kind of, she kind of said, look, steer away from the occupational therapy jargon. You need something that can be measured. And I've just struggled with this question because I'm so interested in the specifics of explicit learning approaches in stroke rehab, and I haven't found a whole heap as such, but what I have found is really interesting. But I don't know how to oh sorry, I just dropped out. I don't know how to word that question around. I know what I'm trying to do, but I'm not sure whether I'm wording it too broadly, which means I'm not actually going to be able to answer it, or whether it's, I think, as Laura did, a scoping review, but then I'm not, I just kind of, I guess I need a bit more guidance on how to word that question.
No, that's fine. I think the point I was trying to, I think it's the definition thing. So when you use the word participation as a measurement tool, that actually means specific tools that you would use. So, for example, the community integration questionnaire measures how often and how successfully people go into the community. So that's a participation measure.
Okay,
There's, the GAS goal, which measures perhaps performance on an activity. So completing a functional activity. So it's just the definition of what assessments. Like the sense.
Yeah.
I'm not sure they have a participation measure, but that's
no.
So it's just really going back and having a think about exactly what outcomes you want to see. So if it's about being able to do an activity, I don't know, Laura,
I'm just thinking, is it performance, not participation?
Well, I think it's probably performance. Yeah. Because I think the way you described it was activity performance. So talking about doing a functional activity kind of.
Yeah.
Which is different to, yes, I can catch a tram when I'm with my OT.
Yeah.
But go and measure the client, and the client goes, oh no, I never go out. And I never actually participate in the community.
Yeah.
And it may be because they forget where to get to the train station, or they don't have the motivation, or they never get out of bed early enough when the trains are going. So the participation is different to whether they can do an activity. It sounded like you were talking about performance.
Rather than,
And I think the sense is when you think about task-specific occupational being able to do something because you've got a sensory loss. I think you're right, Laura. I think the word is probably occupational performance or activity.
And can it be because the way I knew you kind of said it to me was you need to be very specific. So what are you trying to measure? You can't just have the occupational performance. Is it performance of what? So that's why I kind of added the activities of daily living, because most of the OT interventions that I've seen at the hospital next door are about ADLs. It's about
ADLs
get dressed. That
ADL is an occupational performance measure, not participation measure.
Yeah, not participation. Yeah, okay. So I can keep, because obviously with that's what I kind of wanted to know, whether I can keep that, because I don't want to just improve occupational performance for adult. I wanted that specific thing in there. I mean, with the sensory retraining, they don't specifically, I guess, it's hard. They don't measure specifically for ADLs, but their intention is that they're doing this so they can participate in ADLs. So that's where I kind of found it a bit difficult to link it up. However, I didn't want to not include the sensory retraining because it is such an important part of the cognitive or the neuro rehab evidence to date for stroke rehab.
Was there none that actually did have that as an outcome? That like performance of their ADLs was an outcome.
Let me just have a double check because I don't think so. I think it was discussed in the introduction of the study that was the intention. I'd need to go back over and actually have a look at the outcome measures. Yeah. I need to go back over and have a look at, because a lot of the sensory ones, they use the same, pretty much the similar. I think it was a Wolf something test. They were using the same outcome measures in that. So for those 3 studies, they used the same, and for the other 3 studies, it was kind of pretty much the same outcome measures because they were, measuring the same things. But actually marrying those 3 articles here and 3 articles here up together with the same outcome measure, from what I remember, I don't think there was in terms of ADL, I guess, outcome measure.
Is the outcome measuring the same sort of things? So is it measuring ADLs?
I think it's measuring. Let me get it up because the sensory ones. Yeah, let me. Sorry.
And remember, you're trying to get a scope. You're trying to get a range of evidence for your story.
Yeah.
Your essay broad question, which is kind of a little bit different to your search.
Yeah. So is this
question?
From reading like what I've read and trying to put this together in my head, we are doing this a bit different than a typical literature review, aren't we?
Exactly. This isn't a purely academic literature review. You need to have a research question that you can search.
Yeah.
So that has to be very specific, and therefore it fits within your PICO, etc., and your systematic search strategy. But then you'll extrapolate that to your question, to your conversation around, return to work after brain injury, and and what are the barriers?
What does that mean for me?
Yeah. So it's useful because you, as somebody who wants to gain some knowledge that you can then think about for your practice, it's kind of then extrapolating it. So this isn't a formalised lit review in the same way, but the process within it that you need to do a systematic search to gain some information to then think about it. So you may start with this, but then add some more information for your background. So, background.
Yeah, okay. Which is why I think I sort of went, that's what I gathered, which is why I kind of went, these aren't necessarily the best evidence ones that I would normally pick if I was doing a literature review and I put them all into levels of evidence. They were reasonable, but I went, they add something to what I want to find out.
About your story, that's right. So you might, the experience of, trying to go back to work after you've had a brain injury is really interesting to gather some information in terms of your knowledge. So that's why I sort of suggested that you can have a range. And that's okay. It's not just purely that, absolute systematic review of evidence per se.
Okay. With this one, this was a case series study back in, I think it was 2013, and it's sensory motor training and neural reorganisation after stroke case series. And they used the Wolf motor function test, haptic objection recognition test, the Weinstein enhanced sensory test, and basically what they were measuring was haptic performance, fine motor performance, upper extremity functional performance, and subjective upper extremity performance. So obviously how the stroke participants actually felt they were doing.
Yeah, so in that one they'll ask them about how you do it in your hand functionally.
Yeah. So I probably can link it. It's just how I link it, I guess. But
in some ways you're trying to explore the outcomes that are of interest to you.
Yeah. So. Well, look, after doing this, and I know that where I'm at the moment, where I'm working, isn't where I'm going to stay. Just because there's only me, there's nowhere for me to go other than what I'm doing at the moment, unless we massively expand in the next 2 to 3 years. And I'd love to go into neuro rehab. Initially, it was pediatrics. But since doing this unit, I'm really, really interested in how it all works and everything. So from my perspective, and not necessarily, I guess, from my settings perspective, I know that this, for me, is giving me a real big scope on what OTs can actually do in the foreseeable future, and hopefully what eventually down the track that this is what OT neurorehab will look like, kind of thing.
And I think what you can, even though you don't work in that area, you could still start to think about, well, what are my barriers to practicing this, you know, that I need to address to be able to then think about that in my practice. And it might be the context, be skills, whatever. So that's how you can, you know, I don't know what you work, I'm never going to know. So it's really up to you deciding, well, what's of value to me to really think about to enable me to be able to put this into my practice. And I think the other, probably the last thing, is that this annotated bibliography process was a refining, getting into it process. So that's why you hand it in now, and part of this is me then giving you some, when I can see your whole thinking, be able to go, oh, maybe this is the direction you need to go, or think about it from this perspective, or, you know, giving you some feedback on that. So sometimes me getting your whole annotated bibliography actually helps me understand your question more than just this little presentation. So get those in, and then I can give you feedback and thinking, and then that can then inform, or not, you can do with what you like, inform your kind of thing. So that's kind of what this process is about. It's starting your thinking, starting your refining your direction, changing your question, all that kind of stuff. So it's that kind of idea.
Okay. Cool. What's the date for getting these in? Is it a formal date? I can't remember what it said.
I said
to get these into you, or is this?
I said on Sunday night at 5 o'clock first. But look, it's a point in the subject that's negotiable. If you want more time, just send me an email. Let me know. But it's really about, you know, time enough for me to be able to read them, give you some feedback, so you've got more time for your essay. But if you say to me, there's no way, it's school holidays, I need another week. No, it's fine.
Can I have another week, please?
Email me.
This is our first school holidays, so it's a bit interesting.
Yeah, that's fine. Look, absolutely. Look, I just named that date because I thought, oh gosh, we're already at this week. But sure. We're post-grad. It's you fit it in your life. Make it so it's useful, not that you're rushing it through.
I would rather, that's what I was going to say. I would rather have more time and actually go, okay, particularly after today and having a chance to just nut it out a little bit.
Yeah, that's right.
To then go, okay, what else do I actually look at, rather than just pulling an article that I'm just
just send me an email when you want to hand it in. Cool. And then at least you've made a date. You have it till November the 6th and you go, oh my God, I still haven't sent it in. So I want you to set a date, but just tell me what the date is.
Okay, cool.
Right. And in terms of critically appraising each, I've nearly completed them all, but do you need side of it as well, or do you just literally want what was kind of put in the guidelines, you know, the boxes with the source, why this article, that kind of thing?
I think I've
you don't need the critical appraisal
of one of the key articles, maybe the one you've chosen.
Like if you've used the McMaster or whatever.
That's right. And then the others just show that you've actually gone through that process, because again, it's about, we know that we're not very good at searching, so let's make sure we do a systematic search. You know, work hard to get the question right.
Yeah.
Actually go through the process of doing a proper appraisal. So you're practicing those skills that we're not very good as in clinicians to then go, okay, here's my story. So I think it says in the guide, there's one you hand in, fill in the table for the others kind of thing.
Yeah, okay. And I think, I guess, I'm gathering that you're wanting sort of our reflections and where our thinking is at with that more than anything else to sort of help.
Yeah. Well, it's that, you know, part of the question was, you know, what's this information useful for you? And you could say, well, that qualitative information was really interesting because it made me have a perspective of actually the experience of trying to go back to work when things are different. And so that's been really useful to guide me in thinking, well, that's some features I want to include when I'm justifying whatever. So that's what it's about. It is your reflection on how that's informed either it's useless and I'm going to go down a different direction, or actually this is what's really informing me in addition to knowing there's no evidence or something.
Cool. All right.
Right.
Awesome.
All right, guys.
Thanks so much.
Awesome. Thank you.
Lovely to meet you both.
Yep.
And I'll
Yeah, you too.
and I'm going to put this and the others, and I hadn't done the others, I'm sorry, but put them up, and so people can also listen and ask questions and things like that. So keep the conversation going.
Cool. All right.
Okay. See you guys.
Wonderful.
Bye.
Thank you. See ya. Bye. Bye.